So it's 12 noon in Central Time. So welcome everyone, and thank you for joining today's PT in Mental Health Lunch Bite, brought to you by Physical Therapy and Mental Health Catalyst Group. I'm Johan Del Paz, one of the members of the leadership committee of this Catalyst Group. Before we get started, just a few quick reminders. Today's session is being recorded and will be available later on the APTA Academy of Leadership and Innovation YouTube channel. If you have questions during the presentation, please submit them using the Q&A feature. We'll do our best to address as many questions as time allows. Tomorrow, you'll receive a brief follow-up email with a link to a short evaluation survey. We really appreciate your feedback as it helps us improve future lunch bites and plan topics that are most valuable for our community. So with that, it's my pleasure to introduce today's session and speaker. Today's session is titled Don't Paddle Against Your Patient, Grab Your oars and paddle alongside them. This session will introduce motivational interviewing as a practical communication approach to help us move from telling patients what they should do to partnering with them in the process of change. We're very excited to welcome Vicky Tobin. Vicky is a physical therapist assistant with over 20 years of experience across acute care, outpatient, and pediatric rehabilitation. She is also a clinical instructor, an active leader within the APTA Pennsylvania chapter, and a mental health first aid certified clinician. Her work helps physical therapy professionals better recognize how mental and behavioral health conditions can influence pain, function, motivation, and participation in therapy. So we're grateful to have her with us today. Please join me in welcoming Vicky Tobin. Vicky, the floor is yours.
Oh, thank you. And thank you, Johan. And thank you, Ellen, for inviting me to speak on this topic. Um, so I'm just going to get started. So, Johan, next slide, please. So our objectives for today's talk is to define motivational interviewing as it describes its role as patient-centered approach in promoting health behavior change and rehabilitation participation. Identify the four core principles of MI and describe the O.A.R.S communication skills. So next slide, please. So what is motivational interviewing? MI is an evidence-based, patient-centered approach. It's used to bridge the gap between prescription and adherence by addressing and resolving a patient or client's ambivalence. It was originally developed and delivered in the psychology field, mainly with those with addictions. But it's kind of expanded into other clinical populations that address several different health behaviors. So in the PT world, how can we apply it? We can use it to improve physical activity, behavior, and adherence to our recommendations, including just exercising or what our plan of care is, and also just health recommendations. Also, with outcome measures, it helps improve the quality of life, especially with health-related issues. It can improve system management, and for those of us in acute care or deal with hospitals, is also shown to reduce hospital admissions. Next slide, please. So what are the purpose? We're going to talk about the purpose, the strategies, principles, and skills of MI. So again, kind of a little bit addressed it with their previous slide, but the purpose is to engage our patients, to enhance their motivation, to support their behavioral change, as well as adherence with their lifestyle habits and their home exercise programs. The strategies, which when I read these strategies, I thought, well, this is kind of almost for those of us in the healthcare field and PTs, this is almost second nature. I think we do this without even realizing or thinking that we do it. But the strategies are to show empathy, develop discrepancies and support, deal with resistance. I mean, that's every day, almost every patient in some aspect. and support health self efficacies. So MI has several different acronyms, and the two that we're going to talk about briefly. Well, the one we're going to talk about briefly are the core principles, which is PACE. So we kind of need to just pace ourselves when we use our O.A.R.S for MI. So the core principles is partnership. So you want to build a partnership with your patients. Again, I think we kind of do this. Acceptance. Um, we need to remember that patients know, we have to remind them that they know their body best, and kind of let them tell us what works best for them versus us telling them what we feel might work best for them. Compassion. Phrases we can use is something that we can simply say, I can tell this is frustrating for you. Um, and evoke evocation, which would be, um, you know, turning to the patient and saying, what would being able to do this task or that task or XYZ, what would that mean to you? Um, those are the core main principles that we use. Again, I think it's something that we do probably on a daily basis, but reading through this information and putting this presentation together for you, it made me realize that I do these things, but maybe now I can do them a little differently, and I have different ways of wording things or looking at the patient or looking at the situation that may invoke more of a partnership versus me being in charge or making the patient feel like I'm in charge. Um, so it makes me think more. And some of the skills for MI, this is where our OARs come in. We want open-ended questions, affirmation, reflection, and summaries. Um, Next slide, please. So I kind of alluded to this already. The strategies, again, kind of second nature. Um, so to show empathy, we just have to remember, we do it without judgment, without criticism, without blame. Um, Develop support. We want to remember to help patients identify the difference between their current behavior and their goals. So we want to kind of tip the balance towards change. So kind of turn it more towards their goals versus what they're currently doing. Um, support self-efficacy is to kind of highlight their strengths, and especially when the behavior change occurs. Also dealing with resistance. So we would need to understand and remember that our perspective as clinicians is not the same as our patients or clients' perspective. So we want to shift the focus on discussion, versus like a lecturing, and hone in on their perspective of things versus our perspective, and make their perspective more of the driving factor of it. Next slide, please. So we're going to go into, I'm going to break down our OARs. So again, your open-ended questions. So it kind of prompts a collaboration between you and the patient. Affirmation helps support the strengths, and convey respect. Reflections helps convey understanding. And summary helps to clarify the motivation of the patient, and provides a little bit of contrast. Next slide, please. So I'm going to kind of break down each of these and kind of go into each of the OARs in a little bit more detail. So again, our first one is open-ended questions. So one thing we need to remember and need to maybe change our approach on how we ask patients questions is to kind of pose our questions to the person versus a person with a list of symptoms or diagnosis. We have to remember that the patients are experts about themselves. So asking the patient about their perspective on their health, and their diagnosis and their symptoms, and drawing on the patient's own wisdom and experiences about themselves. Um, in this way, they're providing the answers. You don't have to come up with the answers. They're providing the answers. They might not even realize that they're providing the answers just by simply them telling you about themselves and you letting them know and conveying that you know that you're listening to them. It helps them to continue to open up to you. Um, we also have to remember to use beginner's mind. Um, so ask with genuine curiosity and humility. Um, approach as if you may know some of the answers, but approach as if you don't know the answers. Um, so kind of increase more of the asking the patient versus telling the patient. We spend a lot of time talking to our patients, telling them about the different diagnoses or telling them why we're giving this exercise to them and what the research shows and what the studies have shown, which is good. But I feel like maybe we should try to, in some instance, try to keep that information in the back of our minds and let the asking be more prominent, especially when the patients are using their own perspective and their own wisdom about themselves. Again, they're experts about themselves. We're the experts about movement and, you know, their diagnosis and their symptoms. Um, kind of think along that way. And the other thing, a lot of times we think about, okay, I'm asking questions. Patients can be so long-winded with their answers sometimes, back in 1933 when I did this, we feel like sometimes we don't have time for that because we're looking at our schedule. So do we really have time to do this? Yeah, we do. Sometimes just a couple questions, a couple of the open-ended questions can provide the information that we're seeking. And the other thing is patients can, if we're spending asking those quality questions, getting that quality information, patients makes them feel as though we're spending more time with them than we actually are. So it's more of that quality versus quantity. So trying to come up with those open-ended questions that will give us that quality information, so we don't have to increase our quantity of time or questions. Um, so our next skill that we're going to look at, next slide, please, is our affirmation. So this is a form of encouragement that taps into the patient's hope for the future. This is where we highlight what we notice about their efforts and their strengths, even in the face of apparent failure. I mean, how many times have we said to the patients and pointed out that they've made progress compared to the last session, or even compared to the previous task that we asked them to do? And they've responded, oh, really? Or, oh, you think so? Um, so kind of reiterating that yes, this is what I saw compared to last session. You were doing this last time and now you're doing this. So kind of keeping those um, failure points down and try to discourage the failure and hone in on the progress that they've made. Especially using, again, our expertise on mobility, we can see this stuff better than they can because they're looking at what they can't do. So it's our job to kind of point out, well, yeah, you can do this, and this is what I've seen from it. Um, and by forming the affirmation, you put the lenses on, um, and we highlight the endearing positive qualities that the patient has. And then we also, again, continue to ask those open-ended questions. Um, ask curious questions about their strengths or their efforts. And once you get that response, just kind of reply back with an affirmation that, this is what I saw, and this is the progress that you're making. Again, I feel like some of this stuff we almost kind of do it automatically. We're always, cheering on our patients and progressing well. This just kind of offers a different way to do it, a different avenue, um, a different way of asking or speaking that will just form a better conversation, a better teamwork between you and the patient. Next slide, please. So a lot of times, you think of affirmation and you think of, oh, well, I'm praising the patient. Is there a difference? And yes, there is. If you look at it in like three different components, you have at the bottom, you have praise, which is your positive comment or judgment about the person's efforts. And then kind of in the middle, you have those compliments, the expressions of esteem or respect or admiration. And then up at the top, that's where you get the affirmation. You get those deeper comments on a person's strengths and their enduring qualities. Um, and I feel like with the affirmation, it kind of has more substance to it versus the praise and even the compliment. Um, so again, you build up that better rapport with the patient, and they just feel, in my experience, it makes them feel more positive, and I think even more motivated to continue to work with you and to try things that maybe they normally wouldn't have tried. Next slide, please. So our next skill is reflection or listening. And this involves paying particular attention to the use of our words. And remember, our words are vehicles for transmitting empathy. So we want to use reflection to engage and connect. We also want to convey our understanding back to the patient. So we want to use those listening statements to reflect back to your patient our understanding of what they're saying, of the meaning of understanding of the meaning of their words and what they're trying to convey to us. Um, and we're going beyond our spoken words, where we kind of have to, venture a guess about what they meant, or what they mean with what they're saying. Um, and several benefits of that is it increases accurate understanding of the patient and their circumstances. We're getting continuing to develop the trusting relationship between our patients and ourselves. And it can also, the conversation can kind of move a little bit faster and a little bit further. Um, because again, we're hoping to convey our understanding of their words, of what, again, what they mean. Um, so next slide, please. So some of the basics for reflection or listening is the speaker puts meaning into words. And then our task is to hear the word correctly, hear the words correctly, and then again decode those words. So in those three areas, there's always the potential of misunderstanding. Misunderstanding from the speaker's part of them sending the message, us receiving it and decoding it. And a lot of times when we don't understand something, and I've know I've probably said this multiple times, I'll be like, oh, is this what you mean? Um, and instead, we should maybe try to use more of a listening statement and more of a venturing a guess as to what we think they mean. So instead of, a patient saying, oh, I don't feel well, a lot of times we repeat back, oh, you don't feel well. And it's no, I don't. And that's kind of the end of the conversation because the patients are frustrated. Another way to look at it is instead of repeating back or saying, is this what you mean? You provide a guess as to what they're implying when they say, oh, I don't feel well. Well, if I'm working with a total knee patient and they're like, oh, I don't feel well. Oh, do you have pain in your knee? It may sound obvious to them, like, yeah, no, no crap, I had surgery. Of course that's going to hurt. But at the same time, when you guess and you're correct, that's kind of the end of that portion of the conversation. Now it's the patient's like, oh, they understand that I'm in pain. Um, versus trying to continue like a conversation. Again, you want to kind of keep everything concise and short, concise and lean, not so much short. Um, so in doing that, you may delete some of the frustration that the patient feels. It may also establish teamwork, and it can add and have a rewarding outcome for both you and your patient. Next slide, please. So the last skill with our O.A.R.S is summarizing. And this is where we kind of pull all of our listening statements together into important content. So it's a recollection of the patient's own words that we are um, verbalizing back to them. So we want to go in a little bit of detail of the patient's words that we regard as important. So pull out those important statements that we heard the patient say. And then we're going to repeat them back to them, um, again, in the short, concise, lean way as possible. So this way, the patient now has to listen to their own words again. Um, and again, they're listening to what they said versus what you said. So it gives them that they're in charge of they're in charge of the plan. They're in charge of their treatment, um, and what's going to happen next, in a way. Of course, we can kind of direct them in the way that would, achieve their goals and work on the deficits that we have seen in our assessment. So again, we can achieve the goals that for the patient and for us. So we kind of want to leave out extra words. We don't want to be like, okay, after we get all the information, be like, okay, so now I'm going to summarize all that you said to me. Instead, kind of leave out I and just be like, all right, so what I've heard you say is these are the things that are important to you. This is what you want to work on so you can do this. Um, so again, it's a way of using the patient's own words as motivation to achieve the goals that they want to achieve. And again, it provides that teamwork that, oh, you listened to what I said. Not only you heard what I said, you're listening to what I said, and now you're applying it to the treatment plan so I can achieve these goals. It's just good relationship building for the patient and for you. So next slide, please. So I found this study that looked at randomized control trials that evaluated PT delivered MI and health-related behavior change. It's from 2024. It's a systematic review and meta-analysis. So what it did, it aimed to determine the effectiveness of motivational interviewing delivered by PTs on behavioral change and patients' health outcomes compared to usual care or alternate intervention. So it included patients, PTs delivered MI that focused on health-related and behavior change, physical activity, dietary intake um, in adults, attending PT rehab with or without co-intervention or usual care. Um, what I was a little slightly bummed that some of the exclusion criteria was mental health conditions and or addictions and any MI that was combined with other behavioral interventions. Um, I just felt like it would have been interesting to see the mental health conditions, but they focus more on the PT aspect of it. Um, Perhaps maybe a future studies will look at the mental health conditions, especially as the PT world grows in the MI in the mental health condition area. Um, so next slide, please. Really, wait 5 minutes? Oh goodness. Oh geez. So as you can see, the publications were from all over. Um, There was Europe, Australia, Canada, and the United States. The diagnosis was COPD, coronary artery disease, cancer, hip fractures, and total knee replacement. MI sessions were done via telephone or in person or a combination of the two. Next slide, please. Um, and the next slide shows all of the outcome measures that were used. There's quite a number listed there. So the results showed that there was a moderate certainty evidence that showed a slight increase in physical activity. Um, there may have been an increase in the quality of life outcome measure, and may have been an increase in the self-efficacy. Um, there was no effect on physical activity, and there was some likely improvement with the self-efficacy, but had a little or no effect to the quality of life or endurance. Um, so discussion, there was a small effect on behavior change with MI and a slight improvement on physical activity, but the positive findings showed that physical therapists can proficiently implement MI as intended with relatively modest training and support. And it particularly was beneficial for patients where physical inactivity is prominently driven by psychological factors rather than physical factors. Next slide, please. I also found a case study that looked at a 57-year-old woman with a 3-year history of pain in the neck and the back. And her goal was to walk more than 1 mile and return to using a stationary bike. The PT that did the eval showed that identified that fear avoidance of physical activity was the important barrier. And the patient also had a demanding job and was caring for her father. The PT used open-ended questions rather than a checklist-style interview, demonstrated empathy, used affirmation and reflection, and respected the patient's autonomy and allowed her to participate in developing her exercise plan. The first manageable goal was to 5 minutes of exercise a day, and then gradually increase walking by 5 minutes per week and exercise volume by 1 set per week. So the outcome measured showed that um, she had the FABQ decreased from 70 out of 96 to 47, so a 23-point improvement, which exceeded the MCID of 13 points. Her pain decreased from 5 to 0. The patient progressed to 5 minutes walking per day, and she reported regular aerobic exercises 3 to 4 times per week compared to no regular exercising. So it's one case study, but it kind of shows that us as physical therapists and physical therapist assistants can um, apply MI to our plan of care, and that it can have positive outcomes to it. Next slide, please. So my cat Finn helped me out, and when I say help me out, it was him sitting on my desk, so I had to put the keyboard on my lap to type. but he wanted to tell you some resources for MI that include a book called Motivational Interviewing in Healthcare, second edition. There's also a podcast, Talking to Change, which I've listened to a couple times on Spotify, which I found very informative. And then there's two websites that I have listed here, motivationalinterviewing.org and Allison.com. Allison.com, um, there's a course, a basic of motivational interviewing course, which is free. And the motivationalinterviewing.org has a lot of different resources that you can use. There's also, I believe there's also training on that website as well. So again, and then next slide is just my references. And then uh, again, Finn enjoyed the book, the motivational interviewing in healthcare book. He really enjoyed that chapter right there. Um, I don't, I don't, I'm not sure if we have any time for questions,
Uh,
comments. I don't
we
think so.
just had one question asking if what
Okay.
were the authors of the books or the studies that you reference. But I guess this is
Oh,
indicated, right?
yeah, this is they're on the slide right here.
Okay, so that's good.
The two, yeah. The first two references are the studies,
Mhm.
and then the third reference is the book, and then the fourth is the website.
Gotcha. There was one question. Are the slides going to be shared? Uh, well, we don't usually have. No one asked that before, so we don't know if we would share that. Um,
I
so
mean,
it's up to you.
I can yeah, I can provide my email address in the comments here
Okay.
in the chat, and then um you just
Or
email me, I can email you the slides.
okay. Yeah.
I'm fine with that.
Gotcha. There. So Vicky has shared her email address there. You can reach out to her for her slides if you want are interested in getting them. And also, it's in YouTube as well.
Yeah.
Later on, so if you want to rewatch it, it's going to be there. So, yeah. So, thank you, Vicky, for sharing with us your time and discussing with us the motivational interviewing. And thank you, everyone, for attending this month's lunch bite. And if you're interested with the topics that we had, the past um, um, videos and webinars or lunch bites are in the Academy of Leadership and Innovation YouTube channel. So you can rewatch that there and stay tuned to our next lunch bites as well. So thank you everyone for coming.
Thank you.
So let me try to this is where I'm having trouble with to ending
Yeah.
the
Yeah. All right.
webinar.
Well, yeah. Alrighty. Thank you so much. This is